then speak a little bit about the recurrence of endometriosis after controlled stimulation in IVF. These are the classification of endometriosis, whether you use the ASRM classification or the functional classification of endometriosis fertility index, or the classification of DB infertility endometriosis. If you are going to do IVF for a patient with endometriosis, you should ask yourself, when should I go for IVF? And we have a long speech about this. Do we have to offer pre-IVF intervention like Abba said? And which protocol? And Abba addressed these things. And what about the success rate? We also spoke about this. And then the specific question about, does IVF treatment increase recurrence or disease progression? And finally, we will have 2 slides about pregnancy after IVF. Does it induce regression like what we have been taught before? These are all interventions that may work for infertility-induced, endometriosis-induced infertility. And this is a very nice systematic review and network meta-analysis by Hodgson that work with Neil Johnson from Auckland. And they show that for infertility, not many interventions work. However, surgical laparoscopy would increase chances of pregnancy, and the confidence interval, like you see here, between 13% increase in the odds of pregnancy up to 2-fold or more increase. GnRH agonists also may work, and it may increase chances of pregnancy, as you see here. If you do laparoscopy and then you add adenosole, this makes no benefit. Pentoxifillin injection, this doesn't work. Dydrogesterone also alone doesn't work. However, laparoscopy and the injection of pentoxifillin does work, and it may increase odds of pregnancy 3 times. And finally, if you do just a simple thing like hysterosalpingogram with injection of dilipidol and not the watery one, so this also increases chances of pregnancy. So after doing hysterosalpingogram, simple things, so you have to wait for the therapeutic effect. And again, our dear Professor Bross and his very elegant paper, Infertility Sterility, about whether to do IVF or surgery. And simply IVF, this should be tried when you have bilateral lesion, when there is male factor or tubal factor infertility, when there is advanced maternal age. Women who have previous surgery should not be subjected to surgery again. Women with initial diminished ovarian reserve. But you should think about laparoscopy if there is no desire for fertility, like adolescents endometriosis, for example, or if there is associated pain, or when you see an endometrioma or you suspect malignancy. Do we have to offer any intervention before subjecting women to IVF? Like Professor Hassan said and mentioned this study about the effect of surgical management of endometrioma before IVF, and does it increase chances of pregnancy? And you can see here that there is no evidence that this increased live birth rate, so it shouldn't be tried. And as regards pregnancy rate, the evidence may be more broadened, and you can see there is no evidence that this intervention increased pregnancy rate after IVF. So the EFRE guidelines, like I said, is if you have endometrioma more than 4 centimeters and it may interfere with oocyte recovery, or you have severe pain or suspicious of malignancy, you can do surgery, and you can have IVF first and then postpone transfer, do IVF on 2 sessions. And sorry for this. Yes. And if you have surgery, what would you do? Would you go for aspiration only or surgical excision? The evidence suggests that pregnancy rates for surgical excision versus aspiration, there is no evidence that one of them is much better than the other. What about the Cochrane review that was mentioned by Abba? Actually, there had been an update of the Cochrane review by Professor Salam that was released in 2019, and Giorgio took the lead in this Cochrane review, and they included more studies. This first plot for GnRH agonist therapy versus standard IVF and XZ alone, and the outcome was live birth. And they included an ongoing, included a trial that the results have not been published yet, and they show that if you are using GnRH agonists, this decrease live birth rate. And when they combine this study with other studies and they aggregate results of this study for clinical pregnancy rate, there was no evidence of any improvement in clinical pregnancy rate by IVF. So I think there is no rule now of using the long agonist suppression therapy. Now, the question about IVF treatment and whether you give controlled ovarian hyperstimulation in IVF, and does this increase the chance of disease progression in terms of pain or recurrence after surgery? Why you may think that endometriosis may progress in IVF? This is because we are stimulating the ovary, producing a lot of growing follicles, rising estrogen level, maybe up to 10 times physiological natural cycle. Also, the growing evidence that endometriosis may originate from ovulatory events, and we are encountering a lot of multiple ovulation events in controlled stimulation in IVF. Edgardo Somiglina has done a very magnificent work, and he did a systematic review to answer this question, whether ovarian stimulation leads to endometriosis progression or recurrence after IVF. And after collecting data from many studies, he showed that he reached a conclusion that IVF does not worsen endometriosis-related pain symptoms, and this is a moderate quality of evidence. Current evidence also does not suggest that there is increase of endometriosis recurrence, whatever you define recurrence in terms of pain or in terms of appearance of endometrioma larger than 1 centimeter. And also the impact of IVF on ovarian endometrioma, if it presents, if it is mild, and this is the low quality of evidence. The only concern was that women with deep infiltrating endometriosis might have a disease progression, and this is very low quality of evidence that they call for more studies to elaborate on this issue. Then about success rate in IVF, this is the systematic review and the meta-analysis with Hamdan et al. In 2015, and it doesn't show any difference in live birth rate between women with endometriosis and those without undergoing IVF. Clinical pregnancy rate was the same as you see here, sorry. And the miscarriage rate was the same. The only concern was about miscarriage rate, that miscarriage rate may be much higher in women with endometriosis. And then there was another systematic review in 2016 that included randomized and non-randomized trials, and it shows also no effect. And then the next question would be about pregnancy. Whether pregnancy after IVF, does it induce regression? For years and years, we have been told that pregnancy is a treatment of endometriosis, and this question has been challenged by Cindy Farquhar and her team in New Zealand. They published this systematic review in 2018, and under the title, "The Effect of Pregnancy on Endometriosis, Is It Facts or Fiction?" And after studying all studies addressing this question, they reached this conclusion. Available data on development of endometriosis during and after pregnancy show fewer beneficial effects of previously reported effects. Women aiming for pregnancy with endometriosis should not be told that pregnancy may be a strategy for managing symptoms like pain or reducing progression of the disease. So what we are used to tell our patient that pregnancy might improve your condition, it has been shown no. As you can see here, here are the percentage of women that do have increase in endometriosis after having pregnancy. This is also, there are some concerns that pregnancy outcomes in women with endometriosis, women may have babies with small gestational age, women may have higher preterm labor, may have placenta previa as well. Thank you very much for this.